بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلاب وطالبات المستوى الرابع، برنامج بكالوريوس طب وجراحة الفم والأسنان، أهلا وسهلا بكم في مستهل اللقاء الثامن ضمن لقاءاتنا التعليمية في مقرر طب الفم. في هذا اللقاء سنتحدث عن المحاضرة الأولى ضمن 3 محاضرات تتحدث عن ال Oral Ulcerative Lesions, which is a wide variance of clinical findings in our society and as a big findings in the oral medicine field in general. In this lecture, we have references. This references the Handbook of Oral Medicine, in addition to Burkitt's Oral Medicine, as well the Oral and Maxillofacial Pathology at a Glance. All these will considered as a textbook as references for the oral ulcerative lesions. The students at the end of this lecture, which is the first part of oral ulcers, should be able to perform a thorough examination of patients with ulcerative conditions and should be able to enumerate the differences or the different causes of oral ulcerative lesions. The students also should be able to integrate the clinical findings with the differential diagnosis of oral ulcerative lesions, which we'll talk about it in this lecture. And also the students should be able to reach the definite diagnosis and provide the patients with the best management procedure for the traumatic and aphthous ulcers. Those traumatic and aphthous ulcers, we'll talk about it in the first part of ulcerative lesion through the 8th lecture. We will talk about introduction and also recurrent aphthous stomatitis, traumatic ulceration, cyclic nitrobinia and Osteoradionicrosis. All these are ulcerative lesions, and I will emphasize in the lecture of the general or the clinical prescription of the lesions. As we mentioned in that lectures, you should do the true clinical prescription of the lesion, and so you should list the differential diagnosis which are the same clinically presented with the presented lesion. So the ulcerative lesions are presented in the oral cavity as an ulcers. We had talked about erosions and ulcers as a similar clinically presented lesions. The erosions, as we mentioned above, are a shallow crater in the epithelial surface, does not cross the basal cell layer and does not reach the connective tissue. But the ulcers are a deeper crater that extend through the entire thickness of the surface epithelium, involving the underlying connective tissue, as we see in this figure. So, how the ulcers are developed in the oral cavity? One of the simplest explanations of the aphthous ulcer pathogenesis are the pictures that presented here. In the step 1, the antigens in the epithelium cross-react with the oral streptococci, and the human leukocyte antigens expression on the epithelium occur. Then the T lymphocytes and the natural killers recruited, so there is an inflammation and there is a problem, so they have to be recruited. Then the cytotoxic leukocytes and the cytokines attack the epithelium, so there is a role of immunity in the pathogenesis of ulcers, attacking the epithelium, leading to this destruction for the stratified squamous epithelium. The recurrent oral ulceration is the most common type of ulcerations in the oral cavity and the most commonly presented lesions in your dental practice or the future clinical dental practice. The lesions on the oral mucosa other than skin or oral tissue or systemic diseases should be evaluated. If Yes? So there is a high risk, so you need to refer this case to the specialist. If no, so these ulcerative lesions are with low risk, so you need to perform a topical corticosteroid if there is a response. Okay, if there is no response, no, you share the management of this case with the specialist. This is an introductory paradigm of recurrent oral ulceration. What are the main causes of mouth ulcers? The trauma and the aphthae and malignant neoplasm and the drugs are the main 4 causes of mouth ulcerations. The main causes of ulcers as a systemic diseases are the blood disorders, infections, gastrointestinal diseases, skin diseases, and immune related diseases. These are the systemic conditions which are manifested in the oral cavity as an ulcers. Manifested in the oral cavity as an ulcer. So there is no ulcer due to local cause. There is an ulcer due to a systemic diseases. So it is a systemic an oral manifestation of systemic diseases. The mouth can be sore for a number of reasons. Dry mouth may lead to oral soreness or soreness. Epithelial thinning occurs in the cases of mucosal inflammation, such as caused by candidiasis, candidal infection, and mucosal atrophy due to geographic tank, as we mentioned in the last lecture, and due to iron deficiency, folic acid deficiency, and vitamin B deficiency. All these deficiencies lead to mucosal atrophy, most commonly in the tongue, leading to the oral soreness. Mucosal erosions also can be caused by radiation-induced mucositis and in lichen planus, in erosive lichen planus. One type of the lichen planus, we called it an erosive lichen planus. Also, epithelial thinning might be due to mouth ulcers due to recurrent Aphthae ulcers, neoplasms, and systemic disorders. Dry mouth and epithelial thinning can also result from irradiation. The patient who undergo radiotherapy due to treatment for the cancers can be complicated in the oral cavity as a thinning of the oral mucosa and dry mouth, leading to mouth soreness. Soreness may be in the mouth also due to subclinical diseases or psychogenic causes or neutrophils or neuropathies. Neuropathies, diseases related to the nervous system, psychogenic causes such as stress and so on, subclinical diseases, any other systemic condition. Ulceration may present or represent a neoplasia, therefore biopsy should be done. The ulcerative lesions, it's very important to be aware of these lesions, so it might be a clinical presentation of serious lesions such as squamous cell carcinoma, and therefore the biopsy should be performed. Ulcers are painful, although an important exception of this symptom is the squamous cell carcinoma, which is painless ulceration, can be presented as an ulcer which is painless, which is often particularly painless when the tumor is small, so it is not ulcerated or presented as an ulcer. Any ulcer persisted in the oral cavity more than 14 days should be considered for biopsy. So there are types of ulcers, either single or small number of discrete ulcers, or multiple discrete ulcers, or multiple diffuse ulceration. The clinical presentation of single or small numbers of ulcers in the oral cavity, you will find just an oral ulcer or small number of ulcers. Discrete ulcers. Multiple discrete ulcers you will find on the tongue, on the buccal mucosa, on the floor of the mouth, on the palate. There is a multiple discrete ulcers. Multiple diffused ulcerations, such as in the cases of vesiculobolus lesions, diffuse ulcerations presented in the oral cavity, like the ulcers resulted from vesiculobolus lesions. The single small number of ulcers, such as recurrent Aphthae ulcerations or traumatic ulcers, and the multiple discrete ulcers might be due to herpetic lesions. Types of ulcers. These are an examples of single or small ulcers. First one is the traumatic ulceration, minor, major Aphthae ulcers, cyclic Nitrobinia related ulcers, and Behçet diseases. We will talk about Behçet disease in the second lecture. Squamous cell carcinoma, also one of the single or small number of discrete ulcers. Necrotizing cyalometaplasia and TB ulcer and syphilitic ulcers. The types of multiple discrete ulcers can be founded in the lesions of herpetiform recurrent after stomatitis, and also Behçet diseases can be presented in multiple discrete ulcers. Acute necrotizing ulcerative gingivitis also presented in the oral cavity as multiple discrete ulcers. The multiple diffuse ulcerations can be founded in erosive lichen planus, lichenoid reaction, and this is vesiculobolus lesions. Graft versus host diseases, which an immune related disease due to grafting from other site. Radiotherapy or radio induced mucositis also presented in the oral cavity as a diffused ulcerations. Osteoradionicrosis also can be manifested in the oral cavity as a diffused oral ulcers. First one is traumatic ulcer. Traumatic ulcer has an etiology and pathogenesis which might be a chemical in nature or physical in nature. The physical causes of traumatic ulcerations may be due to components of dentures, such as the what we called it in the partial denture class, or due to orthodontic appliances such as the brackets or the wires or whatever. Dental restorations which are malformed or maltreated restoration, prominent tooth cusps and cheek chewing, cheek biting, scissors in poorly controlled epileptics. These are physically in nature, but the chemical causes of irritation which may lead to traumatic ulceration, the placement of aspirin tablets or any other caustic tooth ache remedies on the mucosa adjacent to the painful tooth will lead to chemical ulcers due to low pH and the acidic effect. The clinical features of traumatic ulcerations will be presented in the oral cavity as a single discrete ulcer, localized deep ulcer, expected from physical injury and irregular outline, and chemical irritation may present as a more widespread superficial area of erosion. So the chemical appearance of the chemical causes of traumatic ulcer will be appear as slightly superficial lesions, often with a sloughing of fibrinous exudate. There is a removal of white fibrinous exudate from the superficial layer of the ulcer. It will be tender or painful regular lymphadenitis due to these ulcers, due to also the result of the contamination of the ulcer by the oral flora. So the ulcer in the oral flora are exposed to many types of gram-positive and gram-negative bacteria. This may lead to infection and presented as a lymphadenopathies. The differential diagnosis of the traumatic ulcers: primary syphilitic lesions. We'll talk about syphilitic ulcers in the next lecture. Tuberculosis ulcer also, dystrophic ulcer, necrotizing cyalometaplasia, recurrent Aphthae stomatitis, and recurrent intraoral herpes simplex, and also ulcers that occurring due to odontogenic infections. All these ulcerative lesions are a differential diagnosis of traumatic ulcer. How we diagnose the traumatic ulcer from all these differential diagnoses and all these similarities? The cause of traumatic lesion. The cause is the key for the diagnosis of traumatic ulceration. So the history and clinical examination is very important to exclude all other differential similarities. This is a traumatic ulcer in the buccal mucosa due to malformed restoration, and this is a traumatic ulcer in the hard palate. How to manage, how to treat traumatic ulceration? The first key treatment is to eliminate the cause of the traumatic ulcer, such as smoothing of the tooth and repairing of the malformed restoration, such as denture and filling. So the healing after removal of this cause will result within 7 to 10 days in the normal cases. With painful ulcers, using sodium bicarbonate in water. Sodium bicarbonate will reduce the painful symptoms of ulcers, as well as the chlorhexidine mouthwash or benzamine mouthwashes should be also used as an antiseptic to reduce the infection from the oral flora. So you have to treat the traumatic ulcer by removal of the cause first of all, then symptomatic treatment and antiseptic treatment. Local anesthetic agent also can be used as an ointment or gel or an effervescent types. These local anesthetic agents to reduce the pain which is resulted from the ulcer. Any ulcer that failed to heal after 2 weeks should be biopsied to exclude the presence of any grade of neoplasia. The second type of ulcerative lesions is the recurrent Aphthae stomatitis. The causes of recurrent Aphthae stomatitis are not mentioned in the textbook as a single causative factors, but there is some etiologies or risk factors which are related to recurrent Aphthae stomatitis, such as iron deficiency and folic acid deficiency, as well as vitamin B deficiency. All these deficiencies has been found in the patients with recurrent Aphthae stomatitis. Other predisposing factors also which can lead to recurrent Aphthae stomatitis: psychological stress, as well as hypersensitivity to foodstuffs, and also cessation of smoking. Psychological stress, as we see in the students in or at the period of examinations, some of students are exposed to stress due to this situation and presented with Aphthae ulcers. Some foodstuffs also lead to recurrent Aphthae stomatitis. Cessation of smoking lead to Aphthae stomatitis due to that the smoking as founded make the oral mucosa more keratinized, so it will be more resistant to ulcerations, and for this the cessation of smoking, when the patient stopped smoking, the oral recurrent Aphthae stomatitis might be developed. Clinically, the recurrent Aphthae stomatitis may be presented as a minor Aphthae ulcers or major Aphthae ulcers or herpetiform ulcers as the clinically presented in the form. It will be also regular, round or oval ulcers. This is opposite to the traumatic ulcerations, what we talked about it before, which is irregular, the traumatic irregular ulcers. But the Aphthae ulcer, recurrent Aphthae ulcer, regular in shape, painful ulcers with erythematous borders. Also the erythematous borders is a characteristic to differentiate the recurrent Aphthae stomatitis from other traumatic ulcers, and other ulcers. So we have erythematous borders. This is a whitish, slightly whitish ulcer, and with erythematous borders. The borders of the ulcers has a hollow red area. The large majority of patients with recurrent Aphthae ulcers suffer from minor form, which is the most common type of recurrent Aphthae stomatitis, characterized by either single or multiple number of shallow with 5 mm diameter or less, affect the non-keratinized sites within the mouth, such as the labial mucosa, buccal mucosa, as well as the floor of the mouth. In these areas we have a low amount of keratin. The minor Aphthae ulcers are not usually seen in the hard palate and the attached gingiva, which are the keratinized areas, typically heal in 10 to 14 days without scarring if kept clean. Major recurrent Aphthae stomatitis occur in approximately 10% of patients, typically 1 to 3 centimeter in diameter, so it is a major, larger than minor Aphthae ulcer, either singly or 2 or 3 at time, and usually last for 6 weeks. As we see in this clinical picture, this is a major Aphthae ulcer. Major recurrent Aphthae stomatitis also can be presented in any oral site, including the keratinized tissue, and may reveal scarring after healing. So the major recurrent Aphthae stomatitis can lead to oral scarring due to healing by secondary intention. So there is a large area of ulceration, and also the severity and prolonged nature of the major recurrent Aphthae stomatitis can lead to scar. Herpetiform ulcer, this is the third type of recurrent Aphthae stomatitis, which we called it herpetiform due to its clinical similarities with herpes infection. The number of ulcers increased, often involve as many as 50 separate lesions. So this is a minor or herpetiform Aphthae stomatitis, as we see in these clinical pictures. What are the differential diagnoses? What are the similarities of recurrent Aphthae stomatitis, which we should take it into consideration during the diagnosis of ulcerative lesion? Mucous membrane pemphigoid and pemphigus is the first differential diagnosis. Cyclic Nitrobinia ulcers, erythema multiforme ulcers, ulcers due to necrotizing cell metaplasia, lupus erythematosus, erosive lichen planus, and primary syphilitic, atrophic candidiasis, herpetic, stomatitis, herpingina, hand-foot-mouth diseases, bite wound after local anesthesia, and Aphthae and Behçet syndrome, and also the squamous cell carcinoma are also similarly clinically presented in the oral cavity as an ulcers. Diagnosis relatively easily due to the characteristic clinical appearance as we mentioned before, and the recurrent nature. Also, it is an important nature of the recurrent Aphthae stomatitis. The biopsy should be necessary in some patients with major Aphthae ulcerations, since solitary lesions may resemble a squamous cell carcinoma or other deep fungal infections. How to manage the ulcerations? The recurrent Aphthae ulcer should be managed first of all by identifying the predisposing factors. What are the causes or the etiologies of the recurrent Aphthae stomatitis, and also the psychological stress should be also managed before. Avoid foods containing benzoate preservatives and also the potato chips as well as chocolates. Any relationship with GIT diseases, gastrointestinal tract diseases, and menstruation as well as the stress should be also investigated to rule out the etiologies and other systemic underlying causes. Complete blood count test should be also performed, as well as the assessment of vitamin B12, iron, folate also should be evaluated to rule out the causes. Symptomatic relief using the mouthwashes such as sodium bicarbonate in water or chlorhexidine as an antiseptic or benzodiazepine. A mouthwash based on tetracycline also found to be effective to treat recurrent Aphthae ulcerations. Will take 250 milligram capsules broken into water and also use as a mouthwash 4 times daily for at least 1 week. Application of topical corticosteroid also, it is very important to manage the lesions as hydrocortisone, triamcinolone, betamethasone as well as beclomethazones. All these are corticosteroids can be used to treat the recurrent Aphthae stomatitis. This case is for a 42 years old woman with a recurrent increase in severity of recurrent Aphthae stomatitis or ulcerations. In investigations, iron deficiency was found. So after this condition is corrected, the ulcers has been resolved. So it is very important to take into your consideration the systemic underlying causes of recurrent Aphthae stomatitis. Even the psychological stress should be also evaluated of the patient by taking a detailed, clear history from your patient, not just to hurry up to treat the lesion by topical or systemic treatment. You need to first treat the underlying causes if present. Cyclic Nitrobinia. The cyclic nitrobinia is a systemic condition but presented or manifested as an ulcers in the oral cavity. What are the etiology and the pathogenesis? There is an absolute reduction in circulating nephropathies due to leukemia or some blood diseases or many drugs as well as radiation or chemotherapy. All these conditions may lead to cyclic nitrobinia or lead to a absolute reduction in the circulating neutrophils. Clinically, we will find the patient with fever, malaise, and also cervical lymph adenopathies as well as infections and beside the oral ulcer. So due to decreased neutrophils, there is a fever, there is a malaise, there is cervical lymphadenopathy, and also there is an infections. The oral ulcerations on the non-keratinized surface and may be appear as a single or multiple discrete lesions. So it is a single or multiple discrete lesions and prone to severe periodontal diseases. The patient may prone to develop a severe periodontal attachment loss and diseases. The differential diagnosis, the lesions which are similar to cyclic nitrobinia in the clinical presentation is the traumatic ulcer, the recurrent aphthous ulcer, the recurrent intraoral herpes simplex, and also ulcers due to odontogenic infections, as well as the Behçet disease. We will talk about Behçet disease in the next lecture. Also, it is very important to differentiate those lesions from cyclic nitrobinia. How to diagnose the cyclic nitrobinia and how to differentiate the cyclic nitrobinia from other clinically similar lesions. The examination of the peripheral blood should be performed, which will show a reduction in circulating neutrophils during the episodes of the oral ulceration. At the same time of the presented ulcers, we'll take a sample of blood or refer the patient to the laboratory to take a sample of blood and to assess the level of neutrophils at the same time of the presented ulcers. How to manage it? After we diagnose the cyclic nitrobinia and exclude all other similarities and proven the final diagnosis by investigation of the blood, the management will be started as follow. First of all, there is no specific management of the condition. Medical investigations may be needed to rule out other causes of neutropenia. What are the causes of the reduction of neutrophils should be referred for management. According to the cause, we will refer the patient to the specialist. Antibiotics to reduce the opportunity of infection and prevent the oral infections, and also oral hygiene, good, extremely systemic oral hygiene should be started to minimize the opportunity to develop periodontal diseases. Osteoradionicrosis, this is the last types of ulcer or ulcerative lesions in this lecture. Osteoradionicrosis due to, as it is mentioned from its name, osteoradionicrosis. So there is an ulcerative lesions due to pathology or problem in the bones, osteo. The main cause is the radiotherapy, and the pathogenesis is necrosis of the cells. So the radiation affects the capacity of osteocytes, the bone cells, and osteoblast, and the endothelial cells, which are the cells of blood vessels, to repair following injury. So this injury is developed due to radiotherapy in the patients who undergo radiotherapy for the treatment of cancer or other diseases. So this injury of the bone cells and blood vessel cells presented as an ulcers, extraction of a tooth, and periodontal diseases, as well as pre-apical infections are all factors that can predispose the development of osteoradionicrosis. So there is a reduction of the capacity of the cells to healing after injury due to radiotherapy, and the trauma that predisposes the development of the osteoradionicrosis might be an extraction of a tooth or periodontal diseases, as well as pre-apical infections. Clinically, begin following minor trauma to the jaws, as we mentioned the causes. The osteoradionicrosis proportional to the amount of radiation given. What are the doses that has the patient taken before developed 1 year after the radiotherapy completion, and there is some variation 2 weeks to 34 months. The ulcerations and necrosis of soft tissue leaving areas of exposed bone, and this is very difficult to be treated. Clinically also, the small areas of necrosis, typically in the mandible, become larger, and also portions of necrotic bone are then lost. Why the mandible is the most commonly affected and typically presented in the mandible? The mandible, as we know, is formed of compact bone rather than spongy bone as in the maxilla, and the blood vessels in the bone and the blood supply in the bone of the maxilla is more than that of the mandible, so the healing capacity of the lower jaw and the mandible is lower than that of the maxillary bone. So the traumatic tooth extraction, these are the factors that lead to osteoradionecrosis, as well as poor oral hygiene, poor nutrition of the patient, excessive alcohol intake, as well as the other causes of trauma are the initiating factors for developing osteoradionecrosis. How to diagnose the patients with ulcerative lesions as an osteoradionecrosis? This will be established by the history and clinical examination. So the patient in his history will report that he has a history of radiotherapy, and the clinical examination also will aid in your diagnosis. The biopsy of affected area will just show necrotic bones and necrotic tissue, and also sequestration of the bone. There is an area, separated areas of the bone in the histopathological specimen. How to manage the osteoradionecrosis? Prevention is by far the most important management strategy. So prevent the factors. Don't do any traumatic extraction for the patient who has undergone a radiotherapy before 1 year or at the last 1 year, and also other causes should be prevented. Dental assessment of the patient prior to radiotherapy should be started. Any teeth with large or poor restorations and preapical infections as well as periodontal diseases should be extracted non-traumatically. Custom-made soft rubber dental trays fabricated for the delivery of topical fluoride. So the fluoride will prevent or reduce the risk of developing dental caries. So the patient don't need to do any surgical or dental procedures. Any extractions that is necessary following radiation should be also, as we mentioned, done in an atraumatic manner under antibiotic coverage to reduce the opportunity of infection. Once the osteoradionecrosis developed, if it is already occurred, it is extremely difficult to treat, unfortunately, despite the removal of the necrotic bone and debridement, just surgical removal and cleaning. High dose of long-term antibiotic should be started for these patients, and there is a hyperbaric oxygen treatment. Hyperbaric oxygen treatment can be used to treat patients with traumatic injuries, such as injuries due to diabetes or injuries due to radionecrosis, osteoradionecrosis. The patient will be entered to a specialized room. This room is pressured and containing pure oxygen. The pure oxygen found to treat these cases. So in conclusion, in this lectures we had talking about the introduction about oral ulcerations and mouth soreness. and pathogenesis, and also the types and the causes systematically and locally, which lead to oral ulceration. We speak in detail about 4 types of ulcerative lesions, started with recurrent Aphthae stomatitis, minor, major, and herpetiform, and also the traumatic ulceration, cyclic nitrobinia and its management and its also investigation, as well as finally we had talking about the osteoradionicrosis and its management and prevention. The assignment of this lecture is the case presentation of any type of ulcerative lesions, which as are mentioned in this lecture. This assignment also will be provided in the assignment section of the course as an attached Word document under the number of 8, the number of this lecture. Thank you very much, dear students.